All right, everybody, it's 7:10. Let's get back to what we're doing. So, as we talked about, we went over the course guide. We talked about clinicals, hospital, and field. Now, please note that if there may be the possibility of field time opening up before clinical time, I'll find out that more about this tomorrow. But clinical, when it comes to field time, that may open up. So just keep an eye out on your emails, because as soon as that's available, you guys will be eligible to start scheduling for that. All right. And then we've already talked about, going on whether or not we have a Monday, Wednesday class or Tuesday, Thursday. But again, after that July date, I'm looking to hopefully get everybody in based off if we're allowed to. So, we do know that we will be having lectures online for the rest of this semester. In fact, I believe we were told over the weekend too that I need to start preparing all my lectures for online presentation for next semester, for next year anyway, as this they don't know what they're going to be doing, so I got to start prepping all that stuff. But one thing that that is unique in the public safety education is we are the only healthcare profession that is required to take not only a written, which everybody does for their final boards, but we're the only ones that are required to do a psychomotor. So good, bad, or indifferent, if you read the Pennsylvania law, it states that you will be subject from EMR up to paramedic, you will be subject to a psychomotor exam. The only pre-hospital provider that is not subject to that is the PHRN, but they do have to take a cognitive exam. So what we're going to start doing is working on looking at National Registry types of questions. You've all heard the horror stories of the cognitive exam. The National Registry is very, very good at writing exams. They invite subject matter experts out to Columbus once a quarter, and for about 4.5 days, they sit there with textbooks as well as other subject matter experts. Typically, what they'll do is they invite program directors from ALS and BLS academies, as well as medical directors from across the country that specialize in emergency medicine, and we sit there and we write exams, exam questions, and we bounce them off of each other. We're all required to write, when we go out to do this, we're all required to write at least 25 multiple choice questions, and they give us specific rules and policies on what we have to follow. And then since there's 10 of us, we all go down into that meeting. They feed us pretty well too. It's just outside of the Anheuser-Busch plant outside in Columbus. We take those 250 questions and we modify them and we make them better to where there is truly only one question, one answer. So that's what we're going to do. Is I'm going to start getting your brain looking at those exams a little bit differently. We'll talk about the STEM versus the distractor, as well as we're going to start doing case reviews. I'm going to try to do at least 2 per night. Test questions, we'll do 10 per night. Try to, but as well as go back and review a little bit of the content, a little bit of the curriculum on where that information is. So what I'm going to do tonight is we're going to go look at a little bit of just some concepts to help you start to demystify the question process, as well as, and when we start getting into the case studies, that will help you apply your thinking process to the National Registry oral stations. And again, you'll have oral A and oral B with that. So again, throw a chat up, open up, this is supposed to be interactive, and like a traditional classroom. So throw your if you have a question as we move along to discuss stuff, let me know. Okay. So as you know, a couple weeks ago, I took my National Registry Cognitive, and a couple of things that I came out of that exam questioning was basic assessment skills when we look at certain things. So I just wanted to run through, because I know Pennsylvania, when we give report, they want us to use the DMIST and everything else like that. So a lot of people that are running pre-hospital, well, oh, what about DMIST? Well, that kind of lags into a little bit over into your assessment. Oh, demographics. Okay. Well, let's start looking at it, especially what National Registry is going to expect you to know. Well, what they're going to want you to know is sample OPQRST. Okay. And the reason why they do it is because it's simple acronyms. I personally don't care what you use, as long as when you read a National Registry question, you understand what they're asking you, because a lot of the questions that people misunderstand or answer incorrectly are based on medical terminology. So understanding that, everybody here, I believe, understands what sample OPQRST is. So when they want you to do an assessment and they ask a certain question, it is based off of that mnemonic. Okay, so remember, signs and symptoms. All right, sign is something that you're measuring. A symptom is something that something the patient tells you. Any allergies, any medications that the patient is currently taking, any pertinent past medical history. All right. When was their last oral intake? Okay. And any events leading up to the injuries. Okay. Or medical event. And then the OPQRST was when did it start? Was there any provocation? Rate it for me. What was the quality? 1 to 10, 1 being most pain, 10 being most pain I've ever experienced. Is there any radiation? Does it go anywhere? And this will actually come true, when we start talking about ACLS and PALS and stuff like that, how we're able to quantify the patient's signs or symptoms. The quality, the radiation, the severity of it. And again, that quality and severity, it's kind of like, oh, do I really need to do one? It's going to be up to you as a clinician. And then the time when it began. And then the other ones that they throw in there, okay, are going to be the acronym that I use when we do trauma assessments, or even medical. It doesn't matter. Remember, these are universal. You could use them whatever you feel comfortable with. DCAP, BTLS, DCAP, BLS, TIC, or anything like that. This is the ITLS version, because PHTLS, if you ever take an MPAC course, if you ever take a PHTLS course, they don't use acronyms like ITLS does. But again, remember all your trauma stuff when it comes to triage. They're using registry reverts back to the SMART triage system, and that article that I gave you, the MMWR. Mortality and Morbidity Weekly Report back in 2012 regarding triaging of trauma patients. That's what it's going to be drawing from, just like all of your AHA stuff, ACLS and PALS, is going to be drawn from the 2015 circulation, which you have access to, and you should have been reading the entire time that you've been in a program. So DCAP, BTLS stands for deformities, contusions, abrasions, punctures, and or pneumothorax if you're over the chest, burns, tenderness, lacerations, swelling. I stands for instability. So utilizing that. But again, when you start reading these case studies, and when you start looking at a National Registry question, please realize that they more than likely, if they're going to give you baseline vitals, they will give you some offset of breathing, pulse, skin color type, humidity level, pupils, blood pressure, and pulse oximetry. Those are your baselines. When you start getting into end-tidal CO2 and stuff like that, that's when we start getting into the advanced. But you'll find out that the majority of the questions, honestly, are written at the competent entry-level provider, which start with a BLS and your ability to assess your patient. Don't read into these questions. Look at them. Most of the time, they'll give you a roadmap to what you're looking for. All right. Another one that you'll find is question, something where you question yourself, is your Glasgow Coma Scale. There are questions on the National Registry which will ask you, given a certain patient presentation, meaning they will tell you in the question, your patient's eyes open spontaneously. They are verbally responsive appropriately. They obey your command. What is your patient's total GCS score? Well, that's easy. That's 15. Well, what happens when they tell you that your patient eyes only open to pain? What happens when they verbally respond to you in a confused way? So right now you're looking at 6, but what happens if they suffer from decorrugate posturing? It's a total of 9, right? So then what's going to happen is they're going to give you 4 distractors that say 6, 7, 8, 9, and you're going to have to pick that appropriate number. Okay, so going in there and being able to justify a GCS score, you may see a couple questions on your national registry on that. So I would recommend that you go back and you review your GCS and be able to come up and quiz yourself. If you have a patient with this, this, and this, what is the approximate number? Okay, so that's something to be consider. The other one is your AVPU. Okay, knowing what AVPU stands for. Okay, your patient is alert, your patient is verbal, they respond to pain, or they're unresponsive. So on an AVPU scale, they would be AVP or U. I've seen questions on the registry with that, so please go back and review and refresh yourself with the AVPU. The other one, which we'll get a little bit more into when we get into PALS and we start looking at 1 minute and 5 minute and 10 minutes and 15 minutes, 20 minutes postpartum, okay, is going to be the APGAR score. And the APGAR is one of these things that somebody came up with. You know, it's an acronym, okay, where A stands for the appearance or the skin color of your patient, your pulse of the patient, and again, this is a pediatric, a newborn, so you're either going to take it with a stethoscope apically, or you're going to feeling for its brachially, grimace, reflex irritability. Do they pull away? Is their response to loud stimulations like a clap or a cough or flicking the baby's foot or something like that? All right. What is their activity? Overall muscle tone? Are they wiggling? Are they giggling? Okay. And what is their respiratory effort with that? And you'll find out with those newborns what the APGAR score is for. You know, is it absent, slow, irregular, or is there a vigorous cry? So this is based on a 0 to 2 scale, okay, based along that way. So at most, you can have a total point value of 10, 2, 4, 6, 8, 10, or 0 and 0 to 10. So you're going to measure your APGAR score at 1 minute after birth. Okay, and again at 5 minutes after birth. But if there's also concerns, you could do it every minute. You could do it at 5 minutes. You could do it at 7 minutes. But again, you would document this in your PCR when you did it and what time and what the approximate value was. So please realize on your national registry, you can be given, hey, patient looks like this. Patient's pulse is this. Patient's reflexes, their overall activity and their respiration. And then it's going to ask you, what is this patient's score? Now, I know everybody is sitting there shaking your heads at me, flipping me off probably, and you're like, well, that's quite subjective. Yes, it is. But they are very clear when they give you the score, when they give you the terminology in that question. What is this patient's APGAR score? Okay, based on the criteria and knowing what the APGAR means. All right, so please be mindful of that. And again, remember, in your cognitive exam, you are not permitted to take any type of reference material, electronic or written or otherwise, into that exam. So this is all based on what you're able to remember. All right. Anybody have any questions regarding these three slides here regarding the GCS, the AVPU, and the APGAR? I will tell you that when I took my registry, I saw all 3 of these questions. The first 7 questions on my registry were based on PALS and pediatric patients under the age of 5 and congestive heart failure. And then after that, there was a couple GCS and a couple APGARs. So please be mindful of that going forward. So let's talk about registry type questions. All of the questions that you're going to see related to the National Registry are going to be multiple choice in style. They're going to be broken down into what is known as the STEM, and the STEM is going to be this area right here, is also known as the question. Your STEMs are short, sweet, and to the point. There's no extraneous anything in these questions. Now, some people will come back to me and say, oh, well, there was this one question that was very, very wordy. More than likely, that's probably going to be one of the 10 questions that they throw into your National Registry Cognitive exam that are, quote, test questions. Before the National Registry will release a question in a certification exam that is used to actually measure something, it has to be validated at least 400 times. So what that means is they put in questions to see how people respond to it, because there's all these different types of biases and validities, things that they measure statistically to make sure that that question is measuring what it actually means. It's very, very difficult to write these questions, as well as to get 400 points of validity. And that's why the test that you'll take is what's known as a computer adaptive test, meaning the rumors out there is they can prove competency within 3 questions. So if you end up seeing a question being repeated in different formats, meaning, you know, a female patient with a GCS, a male patient with a GCS, that means you missed the middle one. That means you missed the first ones. So they'll keep repeating that until one, they've exhausted the questions, or you show that regardless, statistically, you're not going to get that question correct. And you know, most times you'll see the National Registry anywhere between 70 and somewhere between 180 questions. On average, I've seen most people usually end up shutting off about 120. But again, each person is going to be individualized because they're drawing from questions of anywhere between 500,000 to 750,000 types of different questions, and they're all broken down into operations, ACLS, PALS, all that breakdown, pharmacology, EKG, stuff like that. Okay, so this is what is known as the STEM. It's the question portion. Then we have what are known as the distractors. Those are the answers. And in the National Registry's case, you're going to have 4 distractors. And what they look for is 4 answers that are all plausible, but based on the STEM, there is only one most correct. And what that means is statistically, based on your mastery of the subject, from the individual who understands it at the highest level to the individual that understands it at the lowest level, each distractor has a 25% chance of being chosen by a given individual, meaning it will separate. Those that are at competency and above will choose the right answer. Those individuals that don't understand the concept or didn't read the question all the way through or something like that will choose the incorrect answer. Now, this is where it's always come in. You must choose the most correct answer for that STEM. Okay, so here's an example. Okay, you have a 36-year-old male who is playing basketball and now complains of a dull pain in the center of his chest. His breath sounds are clear bilaterally. His vital signs are a blood pressure of 138/82, pulse rate is 106 and irregular, and a respiratory rate of 16. You should A, administer oxygen by non-rebreather mask. B, asks if he takes nitroglycerin. C, monitor his breath sounds for a pneumothorax. Or D, frequently monitor his irregular pulse. So as a show in your chat, everybody mark down either A, B, C, or D what you believe the proper answer is to this question. Sean got an A. Sam B got a D. Rager got a C. RJ got a D. Mort got a D. Who else are we missing? Brandon, A. Tori got a C. Lorenzo got a D. Sam Grimm and Maria. I think that's everybody, right? 1, 2, 3, 4, 5, 6. Ramey, what'd you answer? I know you're with Scott. C as well? Okay. All right. So let's break this down by distractor, okay? And we'll show you what was going on here, okay? So when you look at this, do me a favor, go back and read that stem again and list for me in your chat room 3 to 4 of the most important words or concepts that you saw in this question and explain why you chose each word. Really, really quick. I'll give everybody about 5 minutes here to do this. Ramey, when you do yours, put Ramey and then yours, please. And I'll mute. Got about 3 more minutes. I haven't seen anybody type in any of their answers yet. All right, good. So irregular. I see Maria. C as well. Okay. Chest pain. Okay. All right. We see chest pain. Irregular. Dull pain chest. A 36-year-old male. Okay. Important in cardiac. A chest pain. Irregular rapid rate. Okay. Chest pain. Irregular. Dull chest pain. Clear equal breath sounds. Irregular. Dull pain. Okay, good. We're picking up on some good ones. And then Ramey, the age of patient is prime for a pneumo. Okay, the patient is complaining of dull chest pain after a traumatic injury. Ramey, can I ask you, where does it say anywhere in that stem that the patient has had a traumatic injury? Okay, no, and that's where we start putting this bias into these stems. Okay, so we start looking at all this stuff here. Okay, um, see, that's what you assume something. No, does it say it in there? Okay. Not, so no, it's not your bad. That's why we're here. We're learning about this. Okay. So, and again, so we're going to that. So he's young. I think somebody had said he was young, or 36. I think Sam B, you had said that, but 36 years old, isn't that kind of relatively young for somebody with an acute coronary issue? Is he out playing basketball? If he had an acute coronary. So those are something he's thinking. You'll see this later, because again, do we ask him? It's unlikely that he's taking nitroglycerin. Most 36-year-olds don't take nitroglycerin, especially if they're out playing basketball, right? He's active, and this is important. This is what these are my thoughts on this. Okay, he's a 36-year-old guy outside playing basketball. That's not your typical cardiac patient, right? Breath sounds are clear bilaterally. Right? I think somebody had led to this with the pneumothorax. Okay. Why is it important? Because when we looked at it here, he's clear bilaterally. Remember, we aren't there right at the time that this dull chest pain started. Okay. If he's going to have a spontaneous pneumo or a pneumo that's working, okay, you're going to know it right away. Okay, he doesn't have a pneumo, and he probably won't develop one now that he stopped playing, and he doesn't show signs of any heart failure, right? The mediastinal shift and stuff that goes along with that. But he has a rapid, irregular pulse. Why is this important? Well, it could be from playing basketball, and his an irregular heartbeat is abnormal at any time. All right, but that is important in this aspect because again, that stem relates directly to the distractors that you're seeing, not to, oh, well, what did I assume? Okay. What did I assume? But again, you guys are going to pick up on that dull pain center of the chest is important, and that's good. But it's not as important at this time within that stem for choosing the most correct answer. And please remember in this, the pressure and the respirations are unremarkable in this patient presentation. Somebody who was running, playing basketball. So asking yourself when you assess your patient, well, what should be good, what shouldn't be good? All right. So here we saw the distractors. Do we administer oxygen by NRB? Which some of you guys chose. Ask them if he takes a nitroglycerin. Monitor his breath sounds for pneumothorax, or frequently monitor his irregular pulse. So after going through and discussing that, does anybody want to change their answers? Okay, Sam, you don't have to bark it at me. Jeez, got to yell at me and everything. With an exclamation point. Jesus. All right. So let's look at this. Those that chose A. Okay. 36-year-old male playing basketball. Ask the students again, is this patient likely to be below 94%? Okay. More than likely not, since he's an active 36-year-old. Okay. Don't go and be that student that says automatically choose oxygen unless there's a reason for it. Now, those that chose A, if we were to change the stem a little bit and say a 36-year-old male who was playing basketball now complains of a dull pain in the center of his chest, his breath sounds are clear bilaterally, his vital signs are BP 138/82, pulse 106, and a regular respiratory rate of 16, and a pulse ox of 83%, then we would change our answer to that. Well, we're, included via non-rebreather without true indication. Well, that's, we have to read this a little bit more in depth. So that's why I'm trying to help you based on what the distractors are. Okay. Now ask him if he takes nitro. Now, in reality, as a competent entry-level paramedic, would you suspect a 36-year-old who's playing basketball takes nitro based on that question and that stem? I would hope not. Okay. Monitors breath sounds for pneumo. Okay. Lungs are clear initially bilaterally. Now we can always say woulda, coulda, dulda, shoulda, but within that stem, okay, he's probably not going to develop anything with that. All right. And then, so D, frequently monitor his irregular pulse. Okay. The irregular pulse within the given stem is the most abnormal assessment in that. So with that, given this question, this stem, and given these 4 distractors, D is the most appropriate answer. Okay. D is the most appropriate answer. So literally sitting there, and I think, Sean, you and I had this discussion offline a couple of weeks ago where you were talking about, looking at questions and what we're going to need to know and all that other stuff. One of the discussions that we had was on medications. Most of the time, unless it's a very particular drug, like nitroglycerin, most of the questions that you'll see on the National Registry are going to be based on the classification of drug, like a benzodiazepine. When we start looking at, are we going to give Valium or Ativan? It's a benzodiazepine. So you'll see generic stuff in there. Just like if you've watched all the ACLS videos to this point, they always start with that disclaimer that says, hey, this is just a simulation. There's sometimes we won't do certain things. That's what the registry tries to do. They try to make things very, very general to encompass, different systems across the country. Just like, Wes had said a couple of weeks ago, if you've seen one EMS system, you've seen one EMS system. So just be mindful of that, read the question, read the distractors, look at it. Honestly, you have 2 hours to take this test. That gives you approximately, at that 1 minute per question, you should be able to, with accurate reading, be able to go through that and click these off. Unless there's math or some type of calculation you have to do, you should be done with these questions within 1 minute. And please realize you are not permitted to go back on the National Registry. You have to decide. You can't be wishy-washy on your answer. You have to decide, take the answer, and move on. You can't worry about the next one or the previous one. You can't go back on that. All right, so give me 1 second here. Let's go and do a little bit of review on this website that I belong to, called LC Ready, Limmer Creative Ready. This is a app that I pay for. It's available on iPad and all in all platforms. I don't know what I pay for it, but it helps me to come up with questions to help you guys. Dan Limmer is a friend of mine. He doesn't give me free stuff. There's 1,000,001 free apps out there that you could utilize, whether it's medic tests or whatever you want to do. I choose personally to use Limmer Creative. One, because I've been part of Dan's test generating process, and he does the same exact process that the National Registry does. In fact, a lot of these questions are validated along with Bill Brown, who used to be the director for the chief executive officer for the National Registry. He's a retired PJ, very A-type personality, but he would always tell us he would go in every week, and when first 2 hours of his when he would go in on Monday mornings would be to take a National Registry examination and to validate those questions. So what we're going to do is I'm going to utilize LC Ready here, and each day we start, we'll get better and better and quicker as we go through it, but we're going to start reviewing some questions that come from this. All right. I don't pick these are just whatever comes out through the system. But just to get you used to some questions that you may see on the registry and written in that registry style of the STEM and distractors, get you exposed to it. All right. So here you can see question number 1. And again, because we're starting ACLS, guess what? We're going to start cardiovascular meds and drugs. Okay. We're going to do about 10 of these just to get everybody prepped and get your brain in the go here. So question number 1, which of the following, let me see if I can increase that a little bit. 1 second. Let me see if I can increase the size here. There we go. So which of the following is the paste form of nitroglycerin? What do you guys think? A, B, C, or D? All right. Which of the following is the paste form of nitroglycerin? Vasotec. What's Vasotec? That's a high blood pressure pill. Okay. Nitrobid is the paste form. Nitrolingual is just a gimme. And then nitrostat is the pill form or the sublingual form of that. Okay, so we were looking for nitrobid here as the correct answer. All right, it's just asking for the paste form, and as you can see here, it gives you a full rationale on what it is. Okay, which antiarrhythmics are classified as class 4? Anybody want to take a stab at that? I will tell you, I don't know the answer to this one. This is and again, this is where I like Dan's stuff, because if I wouldn't know it, I would go back and review it and find out. And that's telling me that I got to go back to ACLS and read what type of antiarrhythmics. And again, I'm just going to, with this, I think the majority of people here I saw said C. So we'll look at C, and hey, guess what? It's a calcium channel blocker. And guess what? That was a sloppy guess. Okay. So calcium channel blockers are class 4 antiarrhythmics. And in that class, we're going to see verapamil and cardizem. Potassium channel blockers are class 3 antiarrhythmics or dysrhythmics. Okay, in that case, we're going to see amiodarone as a class 3. Class 2 are going to be your beta blockers, and those are those OLs. And then your sodium channels are class 1s, okay? And those have the subclasses of 1A, 1B, and 1C, lidocaine, percaminide. I would have to go back and be perfectly honest with everybody, and I'd have to go back into circulation. And this is something that I like this, because this is not a question that I would pull out to quiz you guys on, all right? So Which of the following is not a contraindication to administering amiodarone? Which of the following is not a contraindication to administering amiodarone? So reading this stem is very important, because if you just blow past and don't look at that not, you're going to pick something else. But everybody, I'm assuming at this point everybody's picking D, because we're giving it for ventricular fibrillation, right? Contraindications are cardiogenic, sinus bradycardia, second, third degree block. Okay. And again, here we see what antidysarrhythmics are classified as class 3. We ruled out class 4 as being calcium channel blockers, right? Sodium is 1, right? B, potassium channel blockers. All right. Here we go. If a patient has an allergy to corn or corn products, which of the following medications should not be administered? Looks like everybody's going with B there. I'm going to have to choose B with the group because I've got no clue on this one. Oh, dobutamine. Rager, you would have been right. And how did you know that, Josh? You just do. Oh, okay. What medication is indicated for administration if torsades de pointes is the rhythm occurring during cardiac arrest? Rager's the corn whisperer. Everybody's going with MAG? And you would be correct. Even though it's not clearly established as far as the mechanism for that, torsades remains a class 1 recommendation secondary to that. All right. Question 7. Interaction with which of the following may lead to an increase in nifredine levels in the body? Grapefruit juice, nitroglycerin, calcium, or beta blockers? You didn't read. It's A. Grapefruit juice? Seems like everybody's picking A. And you are correct. All right. There you go. Which of the following is an indication for Tenormin administration? B, hypertension. Yep. Tenormin, again, I had to Google it. It's a Tenorol, and it would be B, hypertension. And this one, I had to look it up. All right. I don't think they're going to get you with that. They'll end up going with beta blockers on that. But again, we're looking for hypertension. Okay, two more, but this is again, seeing how we do on this. Okay, which of the following medications is an antidiuretic hormone? ADH. All right. Epinephrine, Levophed, vasopressin, or DIG? ACD. DIG. What's an antidiuretic? Antidiuretic, to diurese means to urinate, right? So something that stops them from urinating. All right. Epi and vasopressin. Okay, epi or catecholamines. All right. I think it's Levophed. Nope, vasopressin. All right, so it would have been C, with vasopressin. All right. Dig Levophed is vasopressor and epi is vasopressor. Okay. More Levophed. Also, when you get to the hospital, Levophed is usually a last ditch drug, and they call them leave. And usually, most of the time, it's they discuss it as leave them dead. Yeah. Which of the following is not a contraindication for the administration of calcium chloride? All right. So, which of the following is not a contraindication for the administration of calcium chloride? Which of the following is not a contraindication for the administration of calcium chloride? DIG, hypercalcemia, cardiac arrest, or hyperkalemia? I'm going to go with hyperkalemia because hyperkalemia is when you give calcium chloride, right? All right, so that's Limmer, and we're going to do about 10 of those a night. When we come in, we'll start those off, and we'll get through that, and it'll, hopefully teach us across the board a bunch of new stuff. All right, so let's do a real quick case study. And the reason why we're going to start doing case studies like this is because your National Registry oral station is pretty much going to follow this concept. And I know that each one of you has watched the video via the National Registry website on the oral stations and some of the videos that I've given you to watch. Now, this is new. These are slides that come with a certification class called AMLS, which is offered through the NAEMT, called Advanced Medical Life Support. This is the same thing that you'll see with ACLS. Everybody's got their own little version of this, but the AMT comes up with a good product, and they've come out with some good case studies with this. So I just want to run through some this real quick for one here. Okay, and then we'll get into some ACLS. That we'll take a break after we're done with this case study for about 15 minutes, and we'll come back. But again, with this one, we're going to review cardiovascular disorders and conditions that present with chest pain. Because again, we're talking about cardiovascular stuff. Okay, so we're going to apply the knowledge of A&P and pathophysiology to patients who present with chest discomfort. We're going to talk about our assessment styles and what we need to do when we start assessing a patient. Okay, and then what is your ongoing assessment and your overall management with this? So what I want you to do, and again, I know it's kind of hard because we're all online and everything else like that. But what I want you to do is start writing down, if you have a pad and a paper with you, okay, start writing down what from top to bottom, the important information and any questions you want to ask as we move forward. Because with the with the oral stations, you are given a piece of paper and a pencil. Okay, and that's what you take notes on, and everything is verbally communicated. The individual behind the trifold, as well as you. So you banter back and forth, getting all the information. This means that when does the actual call start? When you start gathering data and looking at assessing a patient, when does that actually start? And that's a question for you guys. You can answer on chat. Bueller. There you go. And Lorenzo, CAD info, please realize you won't see that on a national registry, but and try to avoid using that terminology in the oral station. Say at the time of dispatch. But you can say CAD, but that would be my dispatch information. All right. So just be mindful of those operation questions. Be generalized. When are we going to start doing this? That means, Brandon, are you going to become the grammar Nazi? All right. Um, we want to do it at time of dispatch. Okay. So just remember, let's go back and review the major organs in space when we look at chest, the abdominal cavity, and stuff like that. When you're looking at this stuff, okay, remember what's located in the thoracic cavity. What is our separation point? Okay, here we can see the diaphragm that separates our abdominal cavity from our thoracic cavity. Okay, we have the right left lung. How many lobes are on the right side versus how many are on the left? Okay, trachea, larynx, this area right here, your heart and your carina, that is known as the mediastinum. All right, all this stuff that goes around with that. That's important to remember where that is. All right. Also, tracing a drop of blood through the heart. Remember, all right, start at, you can start wherever you want, but most of the time they start in the right atrium, come down through the tricuspid into the right ventricle, out to the pulmonary artery. All right, remember, arteries carry blood away from the heart. All right, down to the lungs and become oxygenated, come back in through the left atrium, through the mitral valve, down to the left ventricle, and out to systemic circulation. Okay? No, Sam, because it then becomes history anyway. All right? So little things to remember. A couple things here. I know it's a lot, but when we start talking about pain, okay, two types of pain that we're used to seeing or having a patient explain to us. That's the visceral or the somatic. The visceral is the pain that is the result of activating the receptors within the thoracic, pelvic, and the abdominal organs. Okay, the viscera, and those are subject to distension, ischemia, inflammation. Okay, but really are insensitive to stimuli like cutting or burning. Okay, these examples include appendicitis, gallstones, chest pain, diverticulitis, and pelvis pain. Okay. And then we get what is known as the somatic style pain. This is stuff that occurs basically think about skin. Okay. This is the pain where we get the skin and the deep tissues, just like strained muscles, connective tissue issues, osteoporosis, cancer, myoblastoma, stuff like that. That's the difference between visceral and somatic style pain. And then when we start looking at other etiologies, when we start looking at those differential diagnoses, what other things can cause chest pain? Give me an idea. And so go ahead and throw up some chat. And what are some other things that can cause chest pain, chest discomfort, anything like that? Heartburn. Okay. What else? GERD. Okay. Brandon. Muscle strains. Okay. What do we got? Getting punched. Okay. Trauma. Pneumothorax. PE. Good. Throwing up too much. Right. We could tear our esophagus. Right. Something like that. Excessive coughing. Okay. Um, some notes that I have here, GI causes, you guys talked about the gallbladder, okay, GERD, esophageal spasms, the vomiting, okay. What about pericarditis or somebody that had dental work a couple weeks prior, okay, now is having chest discomfort, okay. Finding a good history in your sample of PQRST can also um, get you pretty good some ideas to go on there. PE. What about pneumonia? Okay. Pneumothorax. I think Tori, you had talked about that. So anything, excessive coughing, pulmonary issues can lead to that. Okay. Other issues can lead to, neurologic, musculoskeletal, anything else like that that you can think of. So be mindful of that. Okay. And again, as we look down, we've talked about it. You may have issues that end up having, like you guys had said, gallstones, gallbladder issues. Pancreatitis can also sometimes have issues along with chest pain or something like that. So just be mindful when you start looking and assessing your patients. Okay. So let's talk about some chest pain as we move along with this and expand specifically when we look at chest pain, other than what we've already talked about that can cause issues. Okay, what are emergency causes of chest pain, and what additional signs and symptoms can accompany the chest pain? What do you think? What are the two types of MIs, RJ, that we typically talk about in pre-hospital? STEMI and a non-STEMI. Very good. There you go. JK, I'm not RJ. All right. You had to answer though. That's good. All right. What about individuals that possibly have a AAA, right? Some type of aneurysm. How would you know about that? One, finding a history, but also two, um, do they feel like they have a tearing sensation? Retroperitoneally. Do they have pulsating? Do they have a mass, or is there something that they're feeling? And again, hands-on assessment will help you do that. Other issues like cholecystitis, which is your gallstones and your gallbladder issue. Don't forget they'll have a burning feeling that goes into their back and up between their shoulder blades. Gas, belching, pulsus paradoxus, stuff like that. Exactly, as we move along with that. Don't forget 12 leads, in the era of, not saying that we have iStats or anything else like that, getting a good history and doing a 12 lead, if you think it's a right-sided MI, doing an 18 lead or something like that, all of this stuff comes down to the fact in finding what's going on, assessing them. Pericarditis, like I talked about, any dental injuries. Do they have a fever potentially? Fever is a big one now, especially in the COVID age, but that's going to be one of our, markers when we start looking at patients who are have pneumonia. One of the things that we were talking about the other day is they're actually talking about giving in Pennsylvania. There's adequate. There's discussion now at the medical advisory committee on whether or not pre-hospital providers are going to be permitted in the next writing of the protocols to give antibiotics for open fractures. So, our scope of practices start in Pennsylvania, starting to open up, as well as in other states, things like that. So all these things of what are our differentials are going to become very important, you know. So some other non-emergency cases that we're going to see when we look at this picture. Anybody want to take a guess what this figure is up here? What's going on with that? Yep, shingles. Please remember that shingles is a variant of herpes zoster, which is herpes. Okay, and please remember herpes actually in the herpes zoster actually is a virus. Okay, which creates shingles. In chicken pox and everything else like that. Basically, the herpes virus goes and it lies dormant in the nerve tissue, and you'll actually see it in the form of shingles. Will actually follow along the nerve tracks. Here we can see it in the spinal in the nerve tissues here. Notice it comes around, right around T2, T3, and then follows around that brachius plexus and comes out on the arm. Very painful, and everything else like that. So be mindful of that. We also talk about general cardiomyopathy. Takotsubo cardiomyopathy. The cardiomyopathy is that variant also known as broken heart syndrome. With that, typically you'll see a higher concentration around females, perimenopausal, postmenopausal individuals, and it ends up causing left ventricular hypertrophy with that. And the only reason why I know that off the top of my head right now is my sister was admitted over the weekend with that, and she's 41 years old. Be aware of some of that stuff that moves through the patients. Okay, neuralgia, thoracic outlet syndrome, diseases of the heart valves can be problematic. Individuals with back issues, compression fractures, spinal stenosis can also lead to chest pain type issues. I know you guys have seen me in class during first and second semester early on when my neck would be out of alignment or my back would be out of alignment. I would have crushing chest pain that would come around the right side of my chest. And that's all secondary to neurological issues. We've already talked about STEMIs and everything else like that, transporting your patient to the proper location. When you're, hey, Josh, I'm going to pick on you specifically right now. What is the policy or what's the protocol down there in Maryland regarding STEMI? Are you guys allowed to start TPA or anti-thrombolytics in the field down there? Okay. All right. And again, little different things, but again, make sure that you're going to treat the patient appropriately based on the signs and symptoms that you're going to see. So let's dispatch this one for you. Okay. You're responding to a public housing complex for a 24-year-old female who complains of chest and neck pain and difficulty breathing. So what are going to be, as you're being dispatched to this call, what are you going to be your initial thoughts on this? Okay. Okay. So let's get this a little bit clearer for you. Is the scene safe? Do we have situational awareness? So we roll up onto the scene, and here's the entrance right here, and your patient's going to be up here. What equipment are you going to take with you to begin assessing this patient? Sam Grimm, I want you to start thinking like a medic. Okay, Lorenzo, you say everything. Define for me everything. Because in the National Registry, they're going to want to know, I'm going to take in what equipment? Okay. So you make your way up, you see the patient, and they complain of chest and neck pain. Yes, suction. For what? Sam, guess what? Your patient's going to puke on you. That's what. Because as soon as you walk in the door.
She's 24. She can spit it out. She doesn't hear it.
Yeah, well, what happens if they're unconscious by the time you get up there?
I'll call the fire department for a lift assist and tell them to bring my shit up when they get here.
Well, then, at that point, because, now the patient is going to, the patient's mom's going to sue you because you weren't prepared, because she now suffered an aspirational pneumonia, which leaves her on a ventilator, and it was the medic's fault because they didn't have the appropriate suction. Okay. So, but anyway, despite the discussion that can go on, okay, hey, you're going to be out there in the field on your own. You're going to be the one that's going to end up having to justify why you did and or did not do something. Okay, so if you're willing to, die on that hill for that, it's going to be up to you. All right, but you show up, they're sitting there, and the patient tells you it hurts to breathe. What are you going to ask them at this point? Or what are you going to want to do at this point? Okay, history. Lung sounds. Vittles. Okay. Know your history of activities, first time occurrence, any provocation, palpitations. Okay. If we do an assessment, right? Sample OPQRST. Okay, so if we do our primary survey, we're going to do our A, B, C, Ds, and E's, right? And again, this is the doorway assessment that we can easily get when we walk in. But again, you're going to tell in the oral station, I'm going to do an assessment of my patient. One, they're not going to be bleeding, hopefully. All right, she's complaining of chest, shortness of breath and neck pain. Airways open, respirations are rapid, shallow, and labored. You listen to lung sounds and the equal breath sounds, but diffuse rales are bilateral. All right. Rapid, weak radial pulse is present. Skin is moist. Glasgow Coma scale is 15. eyes are 4, verbal is 5, motor is 6, and they're sitting on their couch. All right. So if we end up talking to this patient, and the patient seems anxious, if you have a 24-year-old, now again, Sam B, we're going to refer here to someone's socioeconomic status, okay, not racism, okay, but their lower socioeconomic status. Do you think this individual would have considerations for anxiety because they just called you? And usually what follows, if you work in a proactive system, who also usually follows you into those, or may even be there before you into these scenes? PD. Do you think some people may end up getting nervous because there is a fire truck out there or the PD are out there? And do you think the addition of those individuals can cause an increase in anxiety? You know? So, based on this primary survey, do you identify any life threats? Do you think this patient is sick versus not sick? And what would be your initial treatment? What do you think? Not sick? Walk her to the truck. You're going to walk a short of breath patient to the truck? You think she might? What are you going to do if the patient becomes more short of breath on exertion? You know? Okay. Oh, you guys are killing me. Okay, now albuterol. Right. As long as she's not throwing up, right, Sam Graham? You know, stair chair. Okay, Brandon, do you want to explain that a little bit? Why no aerosolized treatments? Okay, there you go. All right, some COVID issues. So if you ended up wanting to do that, okay, what is a secondary treatment that you could think of based on restrictions of a nebulized treatment? Okay, what else? There you go. All right. Very good. In the world of COVID-19, you're right. But terbutaline, okay, those issues that can go, that we can help along with that. All right. So, what do you think's going on with the patient here? Just given this. What do you think a differential diagnosis, or where do you think your brain is going? PE? What do you think else? Just in generic, if you're throwing spaghetti against the wall, what are you going for here? Anxiety? Okay, but RJ, didn't you say an albuterol? If you're going to treat somebody for something, if you're giving them a drug, shouldn't you have an idea? You know, you think about it. Okay. All right. So let's take a look at just some of the things that popped into my eye. And again, this is just a little way to look at this, you know, different categories, things that will definitely kill the patient, something is critically or a non-critical issue, versus a very likely to unlikely, very likely up high versus down low. Okay. Could the patient have a PE? All right. Sam, I think you had said PE somewhere on that. Is this individual at 24 going to potentially have an unstable angina AMI? Okay, how are we going to work that out? We got to do a 12 lead and everything else like that. Could they be could they be dissecting there? You know, do an assessment on the, and again, all these answers can be found if you assess your patient. Could they end up having some type of acute lung injury? Sure. Pulmonary edema? Is that real? Is that a pulmonary issue, or is that a cardiac issue? Esophageal rupture, drug-induced ischemic chest pain. Again, 24 female, probably not. They have a pneumomediastinum. That's typically follows along with trauma. Possibly a pneumonia. Very good. Very with the rails. Again, do we know what the patient's temperature is? Pulmonary contusion and the musculoskeletal and the pericarditis. Those typically follow along with some type of trauma, post-trauma, pericarditis, especially when we start dealing with dental injuries. And again, asking your patient what's going on. So if we do our continue on, we find out that the patient had a gradual onset of both the chest pain and shortness of breath are getting worse. It hurts worse when she takes a breath, takes a deeper breath. Okay, so that's kind of like on an assessment scale. If it gets worse when I take a deep breath, I can kind of move that cardiac issue down a little bit, right? Sharp pain getting progressively worse. Okay, that typically kind of goes with like a respiratory, and it's going across the chest with radiation to the neck. Okay, that's kind of cardiac. Pains are rated as a 6 on a scale of 1 to 10, and this has been going on for about 24 hours. Okay, a little bit more. When you do your sample, okay, sharp pain in the chest and neck, shortness of breath with a cough, no known drug allergies, no regular meds, admits to cannabis use for medicinal purposes. Okay. She quit smoking about 2 months ago, but she vapes instead. Last time she ate was about 45 minutes ago. She's felt weak, has had some night sweats, and has just been resting. I would tell you with that night sweats, that would kick in a pneumonia. That would also kick in, especially given that her socioeconomic status. I would start looking at any history of potentially tuberculosis, especially when we start thinking that way. And she was a previous smoker and cannabis user. All right. And if we put her on the monitor, this is what we got. Can everybody see that? So we have a 24-year-old female, given these vitals, given this everything here. How would you change your treatment at this point? What do you think? Do you want to do anything else? I agree with the O2. She's at 92%. Her respiratory rates slightly tachypnic at 24. All right, she's got an expired CO2 at 32. She's blowing off that CO2 at that expired rate, with that higher rate. Pressure's 120 over 82. Okay, glucose is at 92, temps at 98.6, heart rate's at 111. You're looking at lead 2 there. Okay, try to slow her down. But why is she breathing fast? Okay, you can't make somebody slow down when they're physiologically having a problem. Okay, so again, if we do a little bit more, okay, eyes, ear, nose, and throat. She's got bloodshot eyes. Heart and lungs, breath sounds, rapid, shallow, and labored. Lung sounds diffuse, rails bilaterally. And I didn't make this decision. I know it's a female. Okay. I didn't do this one. Neurocirculation, motor, and CMS is intact. She's abdomen soft, non-tender, unremarkable. Upper extremities, lower extremities are unremarkable, meaning she doesn't have any peripheral edemas. You know? So we do a 12 lead. And this is what we see on a 12 lead. What do you think? Okay. Sam, you're not wrong. What's going on in that 12 lead? And again, Sam's, you're not wrong. Look at that J point across the board, other than V1. Notice, is this person you think this person's having an MI somewhere along the way? Or is that maybe just, what do you think that's something that's going on that's affecting everything? Well, she's having non-typical chest pain. Yeah, universal across the board. I mean, so a pericarditis, or if we end up having something that's causing early repolarization or something like that, as we move along with that, you know. But again, do we know if it's is this person may or may not be having an MI, you know? And again, we're, flu-like symptoms. Brandon's thinking Coke, could it be early repolarization? Flu-like symptoms, very good. Yeah, there's a lot of stuff going on here, but given 24, this looks like early repolarization across the board of pericarditis. Everything's moving. Also, can't rule out typically a PE, but we do have rails in the lungs. So if we take her to the hospital, we end up doing a chest x-ray, and we see that. What's that? What do you think this is? Right and left. Yeah. Pneumonia. Okay. So some other things that, again, thinking about, the patient admits they started vaping about a month ago and tried several nicotine products. All right. Admits to vaping her cannabis in the form of butane hash oil. All right. So at this point, we rethink things. What's going on? The patient's probably got an acute lung injury, especially when you start looking at a lot of these respiratory-driven illnesses secondary to vaping. All right. So yes, pneumonia. But again, for BLS, if we were going to worry about BLS, monitor vital signs, administer oxygen. She needs oxygen. If this patient being at 24, they don't get any better with the O2, possibly consider CPAP. Earlier on, somebody had commented about utilizing anxiety, maybe. Okay, dropping maybe some, of a benzo on them to get them to slow down a little bit. I said slow the rate, possibly, once we figure out what we're doing. And then, but again, if this patient gets bad enough, we ventilate them or something like that. It might be, depending on how bad they get, down along the way. Okay, but again, regardless, we're going to treat this patient right. I think giving them the O2, giving them an albuterol, possibly terbutaline to help with that. She didn't have a fever, so again, where are you going to take this patient? Is this patient getting signed off, or is this patient going to the hospital? So I think we could all assume that the patient's going to be transported, and they're being diagnosed with a VAPI, which is a vaping-associated pulmonary injury. It's a new thing in the last 2 years with vaping and the burning, like the whole K2 thing and burning of the alveolar sacs and everything else like that. Okay, but again, these patients are going to have progressive coughs, dyspnea, pleuritic pain, fever. Ask them if they've been vaping. Find out what we're going to. Yeah, that's true. But again, I have one, so we're just discussing it. So the thing is, when you take your oral stations, these are things that you need to think about. Cover all the bases, and when you cover all the bases, be mindful that you need to know the indications, contraindications, and dosaging of all drugs that you're going to give them. All right. So patient was admitted to the hospital, discharged 4 days later, showed clinical improvement with steroids. It usually resolves with steroid use, and if serious enough, the patient can suffer from hypoxia, respiratory failure, and require intubation. All right, long-term hospital stay. All right, anybody have any questions on that? I've got 8:37. Go ahead.